Konnichiwa. Today I would like to discuss with you the new bundled payment system in the United States and how it may potentially impact changes in Japan. I would now like to review with you the history of the bundled payment system in the United States, which dates back to 1983, when the first bundled composite rate payment was created using data from 1977, 78, and 79. At that time, it was determined that per treatment would be $128 for independent facilities and $132 per treatment for hospital-based facilities. These payment rates included the routine monthly laboratory services, all dialysis services and facility costs of operation. The modality mix at that time between home dialysis and in-center dialysis for independent facilities was 10.5%. Hospital-based facilities had home dialysis at 23.5%. The mean percentage of home dialysis patients at that time was 17%. Next slide. The incentives in the first composite rate in 1983 were well known and codified in the Federal Register authorizing the payment system. In Section 2145 of Public Law 97-35 gives preference to the rate-setting method that combines two components, the cost of in-facility dialysis and the cost of home dialysis. And secondly, the composite rate would promote home dialysis, reimbursing at the same rate as the more expensive in-facility dialysis. So it was well known by the Congress and Medicare that the rate-setting mechanism would promote home dialysis. Now I'm going to contrast the difference between the original bundle in 1983 and that in 2011. So in the red box is the old bundled services, including dialysis procedures and labor costs, supplies for PD and HD, and they were paid at the same rate. The monthly laboratory tests included potassium, calcium, phosphorus, creatinine, bicarbonate, liver function tests, BUN creatinine, the urea reduction ratio, and the complete blood count, and INRs. Outside the bundle at that time were new injectable medications that were not included in the 1977 through 1979 calculations. These included ESAs, IV iron, IV vitamin D, antibiotics, and carnitine. Also, all other lab tests for cardiovascular disease, for diabetes, risk factor monitoring, cultures, blood cultures, panel reactive antibodies for transplant patients were outside the bundle. The new bundle includes everything in the old bundle and adds now the dialysis labs done by the nephrologists, all the injectable medications including ESAs, vitamin D, IV iron, carnitine, and antibiotics as well as blood cultures, oral antibiotics for IV for iron and vitamin D, and Sensipar and phosphate binders will be held out of the bundle until 2016. This slide summarizes the final payment rates for the new composite payment system. In 2011, it was $229.63 per treatment, with 25% of the units would be paid that opted out of the treatment system by the new bundle. In 2012, 50% of all the payments for the opt-out units would be paid at $234.81 per treatment. By 2013, 75% of those who opted out would be paid at $240.36, and in 2014, the payment rate was $239.02. All providers were now included in the bundled payment system, and the reduction that was noted was because of rebasing secondary to large savings. Now, adjusters were added to the payment rate in 2011, and here I show these are shown in this slide. So for dialysis units that were small and had less than 4,000 treatments per year, they were paid 20% more per treatment for the duration of the life of the patient. But an important note is this section right here. In the first 4 months of dialysis, the payment rate was increased 51% because of the high changes in anemia treatment, use of calcium and phosphorus, IV vitamin D to control bone and mineral disease, as well as changes relative to catheters and hospitalizations. Additionally, acute conditions were paid when they occurred, such as pericarditis, bacterial pneumonia, and GI bleeding with hemorrhage. Chronic conditions were paid for the duration of the life of the patient. These included sickle cell or other hereditary hemolytic anemias, myelodysplastic syndrome, and monoclonal gammopathy without multiple myeloma. These had the noted increases in payments between almost 10% to 2.4% per treatment. Now, the incentives for the dialysis, these incentives for the incident patients were well known. So Medicare coverage for home dialysis pays from day one for all patients under 65. This is in contrast to the fact that over 65 patients in Medicare are paid from day one. This is unique to the U.S. Medicare payment system. So the 51% increase in payment system in the first 4 months would yield a payment rate of $359 per run, a significant increase compared to the base rate. Home training costs were added per run at $51 per treatment, but these are not applied in the first 4 months, since the payment rate in the first 4 months is already $359 per treatment. Peritoneal dialysis home training runs are billed at the in-center rate. This would be the $359 per run for each training run. And as noted here, CAPD training has 15 runs, or some $5,744 would be paid. CCPD training takes longer. Here there's 25 runs, and that would be $8,975 for those treatments. And next, home hemodialysis training for 25 runs, and that would also total $8,975. Remember that the additional home training out past the first 4 months applies, but not in the first 4 months. Now this slide shows the difference between peritoneal dialysis patients, their matched hemodialysis equivalents on the far right of the slide. You can see here that the peritoneal dialysis patients have a $6,000 to $7,000 per year lower outpatient expenditures compared to the hemodialysis patients. This creates the exact incentive that was intended in the payment system to pay exactly the same for hemo and PD. Therefore, you would actually save money on peritoneal dialysis, creating the incentive. This slide shows the distribution of providers opting into the new dialysis bundled payment system for 2012. You can see that 92% of all the facilities and the patients actually were covered under the new dialysis bundled payment system. For the large dialysis providers, 100% of them went in, and for the small dialysis organizations, SDOs, 93% went in. Independent dialysis units, 84% of the patients were covered, and the hospital-based system, only 50% actually opted in. On this slide, we show the Medicare payments for the hemodialysis treatments and peritoneal dialysis treatments between the period January 2007 and December 2011. In the upper part of the graph, it shows the hemodialysis treatments. Between January 2010 and December 2011, treatments increased 7.2%. Over the same time period, in the lower part of the graph, peritoneal dialysis runs from January 2010 through December 2011 increased 15.7%, or double the rate of increase of hemodialysis. This was exactly anticipated by the new bundled payment system, where the two treatments are paid exactly the same, but there were savings that were noted on the previous slide for peritoneal dialysis. This slide shows the trends in peritoneal dialysis and home hemodialysis training runs from 2003 all the way through 2012. You can see the peritoneal dialysis treatments actually slightly declined in the mid-2000s and then began to increase in anticipation of the new bundled payment system in 2011. In the lower part of the graph, where it's daily home hemodialysis treatments, they slowly increased and then stabilized in 2010, 11, and 12 with no increase compared to peritoneal dialysis. This was also anticipated because there was no extra payment system, particularly for the home hemodialysis treatments, And home hemodialysis tended to be a reactive therapy done after the first 4 months of treatment, compared to peritoneal dialysis, which could be done at the initiation of dialysis, and therefore the difference in the training rates. This slide shows the mean change in monthly dose of medications that were now included in the composite or bundled payment system. We show 3 time periods: July 2010, July 2011, and July 2012. You can see on the far left part of the slide, the erythropoietin dose fell 20.5% between July 2010 and July 2011. By July 2012, the dose had declined 38.6%. IV iron doses also decreased during the same time periods. So between July 2010 and 2011, the IV iron dose decreased 14.1%. By 2012, the dose had decreased 21%. IV vitamin D doses also decreased similarly. So in 2010 to 2011, IV vitamin D dose decreased 14.3%, and by 2012, July, it had decreased 15.6%. These changes are what prompted the rebasing of the composite rate and bundled payment system for 2014. During this same time period, blood transfusions were tracked in anticipation that the falling hemoglobins may actually have a collateral consequence that may be adverse for patients. Here, the blood transfusion rates for both inpatient and outpatient treatments are included. You can see between 2010, 2011, and the second quarter of 2012, the monthly patients who receive at least one planned blood transfusion increased from about 2.8% to upwards to 3.6%, and then slowly tapered down in the first 2 quarters of 2012. During the same time period of the new bundled payment system, a tracking system was created to observe whether or not blood transfusion rates changed with the incentives that would decrease erythropoietin dosing and decrease hemoglobin levels. On this slide, it shows the monthly blood transfusion rates per patient that averaged approximately 2.8% of patients between 2010 and 2011. In the beginning of 2011, this increased to approximately 3.4% per month, and by 2012, it had increased to approximately 3.8% per month. In the latter part of 2012, in the first and second quarters, you can see the percent of patients receiving a blood transfusion in a month actually began to decline. It is unknown whether this trend will continue because it takes complete data from hospitalizations and outpatient treatments to track this. So during this same time period, the transfusions have increased, but may be returning to 2010 levels. But once again, you need the full year's data for 2012 and 13 to be sure. On this slide, we summarize the changes in the prospective payment system. The incentives for home therapies, and particularly PD, are clear. The incentives were well known to CMS and Congress, and they were part of the principles in the 1983 first composite rate system. The growth in PD is clear, but the question is whether or not it will be sustained. And the new bundled prospective payment system has had the intended impact on reducing costs to CMS. And lastly, careful monitoring of patient outcomes is critical to ensure the quality while a new bundled payment system is implemented. This concludes the review of the U.S. payment system, and I hope it is instructive for those of you in Japan who may be facing similar changes. Thank you.